There's nothing in this world that scares baby residents and med students more than this. And I can't decide if it's because some of these patients are peri-death or if it's because the flowchart of management is so convoluted. It's your best friend, AFib. Let's pin it down for good right now before the literature changes again. Causes of AFib: hypertension, coronary artery disease, heart failure, valvular disease like mitral regurg, age, OSA, hyperthyroid, alcohol like holiday hearts, stimulants, infection or sepsis, pulmonary embolisms, post-op, or electrolyte abnormalities are all culprits. These patients present with palpitations, dyspnea, fatigue. They might be in RVR, usually between 120 to 180. So how do we diagnose it? Get an EKG. What will the EKG show you? No distinct P waves. The baseline is fibrillatory and chaotic. They'll have irregular R to R intervals and a narrow QRS unless there is a pre-existing bundle branch block or Wolff-Parkinson-White. The first four in your management is unstable versus stable. Unstable patients, which would be hypotension, ischemia, pulmonary edema, or syncope, they win immediate synchronized cardioversion. And you'll usually want to use 120 to 200 joules biphasic. Give heparin here if you can, but don't delay the shock. Stable rhythms, you have to then for rate versus rhythm strategy. So if they're stable with RVR, the first line is rate control. So in patients with no history of HFrEF or decompensated heart failure, you can either do a DILT IV bolus going to an infusion or IV metoprolol going to a PO option. Diltiazem, calcium channel blocker, usually has faster rate control and is often more effective at acutely lowering the heart rate. Titration is also really easy here. So you can start an infusion right after the bolus and adjust to a heart rate goal. And you get a lot less rebound tachycardia, whereas beta blockers might wear off faster with small IV pushes. You also can get bronchospasm from beta blockers, so if they have a history of COPD, DILT might be preferred. Metoprolol, on the other hand, is preferred sometimes because it's safer and reduced ejection fracture or a history of HFrEF, especially if they're decompensated, because DILT can cause negative inotropy. You also get less hypotension with beta blockers, whereas DILT can drop your blood pressure more significantly. If they have Wolff-Parkinson-White or a history of it, and they'll have an irregular wide complex AFib, you might see that upslope and a shortened PR, right? You really need to avoid AV nodal blockers like DILT, beta blockers, or digoxin. Use procainamide or immediate cardioversion. Rhythm control, so this can be chemical or direct current. When do we consider this? So if this is their first episode, they're highly symptomatic, or rate control fails. If the onset is less than 48 hours, you can think about chemical control like amiodarone, flecainide, or propafenone if they have structurally normal hearts, or you can do direct current cardioversion. If they've had this for greater than 48 hours or they're not quite sure, then they'll need a TEE guided cardioversion greater than 3 weeks after they've been on anticoagulants at home. How do we make the decision to anticoagulate these patients? CHADS VASC. This is a scoring system on ND Calc. So fill this out, figure out their anticoagulation status. A score greater than 2 in men or greater than 3 in women, they win Eliquis or Xarelto. And the big fear here is that this little fibby atrium is making little clots. So if you cardiovert them, you can shoot those into their head and give them a stroke. Now that you've decided to anticoagulate them, then you get to do the HAS-BLED score. And this gauges a bleed risk putting them on these DOACs, but it's not a reason to withhold if the stroke risk is high. You want to mitigate when you can. Coming inpatient, you might consider Lovenox or even a heparin drip. Otherwise, you can do your Xarelto and Eliquis outpatient and have them follow up in CARDS clinic.